Hi everyone. This afternoon session is an introduction to welcome you to UK medical practice, and it's taken by Tista from the GMC. Thank you, Tista.
Thanks, Shavana. Hi everyone. So first thing to say is welcome. Whether you are thinking of practicing here or whether you started a little while ago, welcome and thank you. The NHS would be very different without you. So we're really grateful. The plan for today is to explore some of the challenges, because I want to give you a realistic picture of the challenges in UK practice, but then explore a lot of the opportunities as well. And then we'll have a bit of a taster session on the induction that we do at the GMC. So that's my sort of, I want you to be able to leave understanding what resources are available for you as well. So that's my plan. But before we get onto all of that, just by way of brief introduction. So I'm Tista. Hi, and I have been in and around the NHS for about 25 years, which is quite scary. And I work with survivors of abuse in our sexual assault referral centres. I work in psychological therapies. And I do other work as well. So I set up pathways in end-of-life care, child protection pathways, etc. And about 10 years ago, I was asked to join the GMC to set up a support service for doctors on the ground. And I remember being really excited and thinking this was a really progressive thing for a regulator to do, because often and traditionally, regulators don't help the profession that we're supposed to be working with. So I thought, yeah, this is what everyone should be doing. So I jumped at the chance, and then at one of my very first conferences, group of GPs as it happens, I was introduced onto the conference stage to the theme of the Imperial March, Darth Vader's theme tune, for those that don't know. And that moment, whilst they were partly joking, it crystallized for me just what fear the GMC can be beheld in. And I understand why. But we're thought of predominantly in fitness to practice terms, but as I learned more about all our functions, and these are all our functions here on this slide, it became really, really clear to me that standards, that's the absolute fulcrum of what we do. And more important, I would argue, for patient safety than fitness to practice, because the really serious fitness to practice stuff we see applies to such a tiny minority. So the more that we can help you deliver complex standards in an increasingly challenging environment, and it's been increasingly challenging pre-pandemic as well, well, that is morally the right thing to do. So we have an outreach team. That's my team. And this is what we do. So wherever you are, at local level, there is an outreach advisor who can provide, who can come and meet with your group, with self-directed learning groups, teaching sessions, etc., and provide support. And this is us doing some of that. A lot of our support is around the standards and guidance. So that's a bit of brief background. So now let's look at UK practice. And if we can launch the first, we've got Slido going. So if we can launch the first poll, if you can just type in some short phrases, some words about your concerns that you either have if you're completely new to UK practice or thinking about it, or indeed concerns you had when you started, if you started a little while ago. And I will try and keep an eye on the chat as well as we go through, but please do feel free to message me. As I say, my DMs are open if there's anything that we don't cover today, because we only have a short time today, really, 45 minutes. Okay. Right, so we've got some thoughts now. Okay, that one of those, as you can see on there, that's really concerning. Filling diversity quota is what I've been told. That's horrendous. And that aligns with one of the other points, racism. Yeah. And I don't know if you're able to attend an earlier talk on racism. I think that is incredibly important. We'll be covering that to a degree today. Where can I get help? Absolutely. Adapting to life. Yeah. And different cultures, which is a huge one, culture shock. Okay. I'm just going to take an image of that because I think these are such important thoughts that we all need to be thinking about this. Okay. So let's have a look then at a list. And as I'm putting this list up, slight change of tack, but as I'm putting this up, I want you to be thinking, what do you think this list represents? It's a real list that was given to me by a friend who started UK practice. So there you go. What do you think that is? And if we can just type into the poll to Slido, what do you think that represents? We've got some answers coming in. Right. Yeah. Essential info, essential knowledge, mandatory training. Oh, local hospital policies, skills to equip oneself. Yeah. It's fascinating to me. This was, my friend arrived from Sudan, and this was her induction. This was the totality of her induction. Where is the welcome and thank you? And this is how the NHS works, by the way. And, you know, we're so great. Where is that welcome and gratitude? Where is the, this is how this complex system works? Where is the, these are what patient expectations are like in the UK. This is what it is like working in a multidisciplinary team in the UK. Where is the culture shock? And you were talking about that in the previous question. Where is, well, where's the support? It's disgraceful that in some places, this is the gamut of induction available. Absolutely disgraceful. And these are from some focus groups that colleagues and I have run with internationally qualified colleagues. And I'll just let you read their reflections, their reflections of starting UK practice. And that penultimate point, I'll just give you a bit more detail about that. I got the catheter from the cupboard as instructed, which is interesting, instructed as well. I hope that they were asked nicely rather than instructed, but. And in that scenario, what happened? The doctor in question, his country of practice, one type of catheter. Here, you do have male and female. And he picked the female catheter. He's working on a male ward, but the cupboard had both male and female. I think it had all the 3 different types we have here. And there are system issues there, yes. But this doctor, who is fine now, by the way, and the system has learnt from not supporting him. But it is absolutely disgraceful that this catastrophe happened to the patient and to the doctor. It's nothing to do with clinical practice. It's the support that should have been provided. And we've done a lot of research on this, as have many colleagues across the system. And these are some of the themes There is early support that's needed with things like issues with visas and, as we saw in the previous slide, what the local area is like. But induction into culture and language of the NHS. We talk about TTOs or TTAs these days in some places. What does that mean? We talk about taking OBS. What does that mean? The language of the NHS is something that needs to need support with. And this is a rarity, but it might be things like things that just haven't been covered. That UK practice is different. So there are lots and lots of challenges. There are other challenges as well, and there are two reports that are really recommended reading, and these are reports that we had commissioned a little while ago, 2019, not that long ago, but obviously the pandemic makes everything feel a long time ago now. And these show, some of you mentioned racism, and these talk about these issues, particularly Fair to Refer, which talks about the broader context there as well, and caring for doctors, caring for patients is around well-being. So we see issues. One of them is that inadequate support when transitioning to, let's face it, a wildly different environment. And then where the structural, if not direct, racism comes in, is doctors being treated as outsiders. The lack of honest, timely, early support and intervention, early feedback of this isn't how it works, this is how it works here, what help do you need? So there are issues, and some of these are again highlighted in that second report around well-being. And this is broader. This isn't just internationally qualified doctors. We see this in the system more broadly, where in some places doctors don't feel they have that voice. They don't feel they have that autonomy. They don't feel like they belong. And they don't feel like they can be competent, not because they're not competent, but because their environment is not letting them because of the high workload. And this is, as I say, 2019, pre-pandemic. There is also lots and lots of good practice going on. So there's call to action, there are recommendations to ensure that there is consistency, but there are case studies that show that actually there are lots of places that do get this right. And I was talking about induction earlier, and there are some places that do fabulous welcoming inductions, meeting their new international colleagues when they arrive, when they land, and providing ongoing support throughout. And that's what we want to see more of. I hope that Claire, our current chair, won't mind, but I'm quoting a previous chair because this has been the philosophy for a while. Our role, we need to support doctors. And I would argue that's not just to keep patients safe, but because it's the right thing to do to support colleagues. So supporting a profession under pressure, whether that is international colleagues arriving, whether that is those who have been in the system a while, that is central to what we do. And because we're talking about welcome to UK practice today, if I had all afternoon with you, I'd talk about a number of different areas and welcome a discussion. But I'm going to hone in on support that is available specifically for your journey in UK practice. So let's look at that. There are, as I said, pockets of good practice, and more widely, there are loads of organisations that I cannot emphasise enough provide some of the gaps that have been highlighted in research. And one of my top takeaways is knowing what is out there for support. And that ranges from peer networks, Doctors Mess, Head Start Project, great peer support there, to formal bodies from medical defence to the BMA, to knowing where you can go to speak up. Every trust has a Freedom to Speak Up Guardian in England, and there are similar systems that are being looked at in national offices as well. And directly from the NHS. There are many, many resources available. I have to say a number of these have come during the pandemic as that well-being issues were writ large. But it's a good resource. It shows what there is available. Okay. And there's loads from us as well. And I'll delve into this more deeply, but there on our website you can find case studies, you can find decision-making flow charts, you can find e-learning, you can find all sorts. And my focus today is going to be, as I said, on Welcome to UK Practice. One of our resources, it is an induction that we developed because we could see that this is needed across the system. At the time, there wasn't any ownership centrally that, yes, okay, as the NHS, we will do this. So we created one ourselves. And necessarily, because it's GMC, it focuses on GMC areas and our standards. But those who run it within my outreach team, we are also experts in other areas on the wider support available, the culture shock, etc. It is only a half-day workshop. Yes, there are some other resources, as I highlighted before. So we do think that there needs to be much, much more, and I'll come to that. But despite it being a half-day workshop, it works. And I'll let you read that. So these are from evaluation forms, but we also had academically robust evaluation. And that shows that even at follow-up, people had changed their practice to align with expectations of UK practice. People had a better understanding of support available to them. And then finally, the final sort of point on here, speaking to the wider picture, some of you may be aware of Prof Marla Rao. She is the medical advisor at MRES, that's the Medical Workforce Race Equality Standard that the NHS run. And she and I and many other colleagues are working on a standardised induction, which we hope that the NHS will roll out so there is even greater consistency. GMC induction will be a part of that, but as I say, there is a need for ongoing support. And I'm really hopeful that that will be provided through this final work here. But in the meantime, I've shared some of the resources that are available right now. And let's look at as well at Welcome to UK Practice in a bit more detail. And I cannot recommend, even if you've been here a while, even I've found that those who qualified here find it useful. Please do sign up. You can sign up for it on our website. But I'm just going to give you a bit of a taster of the kinds of things that we cover in Welcome to UK Practice, and that is what we will do for our remaining time in this session today for the next 20 minutes or so. So one of the exercises that we run with you, and when it was face-to-face, we used to do it in the room with people moving around the room. Currently we're doing it online, but one of the scenarios that we look at is, what would you do if this scenario arises? Would you sometimes, would you always, would you never take a certain approach? So let me give you a scenario. And that is your sister, Elora, is traveling overseas in the next couple of days. She is asthmatic and hasn't had time. She's got an extremely busy job as well, not a doctor, but an extremely busy job as well. And she's not had time to get her salbutamol, her prescription filled. And she needs her inhaler. And she says to you, and this was normal practice back home, and that makes it really hard. She says to you, oh, can you fill my script as usual? Can you get my prescription sorted? So in this type of scenario, where a friend or family member is asking you to fill their prescription, what would you do? Would you sometimes, always, never write that script for your family member? Can we launch that as a question, please. There we go. Okay, so what do you think? Can you prescribe for her? And we've got some answers coming in now. Give it a few more moments as the answers come in. And shall we see how people are voting as you continue with your answers? Interesting. Yeah, I'm glad we don't have any alwayses. And never, if you've got a couple of days, yeah, you're not going to prescribe for her. Sometimes might be appropriate. Let's say it's that evening or something. And this is where the guidance comes in, and our standards, to be clear, take account of UK law, take account of the wider ethical framework and put it into a more digestible set of documents for you. That's good medical practice. And in this scenario, it could be, as I say, if it's that evening or something like that, it could be sometimes, because we say wherever possible, you must not prescribe for friends or family. But there might be, for example, an emergency situation where you have to. So in the workshop, we explore that in a lot more detail, but it gives you a flavour of the kind of thing we explore. Now, I'm going to share a complex scenario with you. And in the workshop, we look at video scenarios. But I'm just going to give you this one. Okay. And I'll let you read that. And this is complex. And I'm going to ask you 3 questions around this. And they are around what the bottom line is around what you do when Talia is your patient. So can we launch the first question, please, Shavana? Okay. So she's a competent adult, as it says here. What do you think? Do you have to disclose? Do you have to breach a confidentiality? Can you see some answers are coming in? And I will bring Talia back as a whole person and explain it all eventually, but we'll go through each sort of area first. Right, as you're, we've got a few answers in now, so can we share the results? Absolutely, the majority have it. Now, the situation may be more finely attuned, and you may, through your conversation, of course, the best thing is if you can get her to safeguarding, and you may be able to have that conversation where you say, I'm really, really worried about you. My friend Jan is really experienced in working with women who are facing the same kind of situation as you are. I'd really love it if you would have a chat with her. She's bound by the same duties of confidentiality, etc. And that kind of conversation can lead you to ease a path to referral to safeguarding teams. But the bottom line is, as a competent adult, if no one else is involved, i.e. if there's no child in the picture, then you can't disclose. So can we look at the next question then? Oh, sorry, Shivani, can you launch the next one for me, please? There we go, thank you. Right, so do we have to disclose her status to a GP? And look at the language of that, do we have to? Okay, and let's look at the results. Absolutely. Again, well done. The majority have it. You don't have to. Now, ideally, you want to. You want to get to a place where Talia is happy for you to breach her. Well, for happy for you to share information, sorry. But we'll come back to why you don't have to. So let's just look at the third question, though, before we do that. Can you launch the third question, please, Shivani? And this is where it's really hard, because I know you'll be thinking, well, what if this time he kills her? If there wasn't domestic violence in the scenario, it makes it much easier. Then, of course, you arrange partner notification. But in this scenario, do you have to? What does UK law, what do UK standards say? And let's have a look at the answer, or how you've voted. Brilliant, brilliant. And I think you are really thinking about the language of the question, because again, the bottom line is what we're looking at. Do you have to? You don't have to. You would want to. You would want to work with Talia to get to a place where you can. And let's look at what these standards say. And again, in the Welcome to UK Practice workshop, what you'd be doing is you'd be looking at the standards, you'd be having a discussion around it, and then bringing it back to looking at exactly what we say. So in our confidentiality guidance, we say that as per UK law and ethical standards, have you got consent? In this case, we haven't. That's easy. Then you can share information. Does the law require you to? Actually, there is nothing in statute, and clearly there's no court order here or anything. There's nothing that requires you to breach confidentiality in this type of scenario. And that means you're looking at public interest test. This is just a useful mnemonic clap, which is slightly hilarious in sexual health scenarios, but never mind. But it's a useful mnemonic to think of what you must consider before sharing information. So how does the public interest test work? Well, you're weighing two things initially. Benefits to, in this case, an individual or wider society would be Talia's partner, or wider society if they're both, let's say, sleeping with other people, versus harm to Talia. As we say this time, we might be worried that she would be, he might kill her. So that's the initial balance. But then you also have to think about the wider public interest in a confidential medical service. So what I mean by that is, let's say, a sexual health clinic gets a reputation for not being, not protecting confidential information. The risk there is that patients will stop presenting altogether. And then that is a wider issue. That is a wider public interest issue. So there's a lot to weigh. And I'm not saying that that suddenly makes the answer really clear. But it just demonstrates how much there is to weigh. And I find it really useful to think about ethical dilemmas in this way. What am I thinking about? And every individual detail makes a difference. So let's say that there was a child in the household. Well, that changes the balance. Let's say that Talia's viral load is 0. That changes the balance. And scenarios like this, where they are complicated, however experienced you are, always speak with a colleague, always get advice. There's loads of advice available, 24-hour helplines from medical defence organisations, for example. But, I'm experienced in the Sexual Assault Referral Centre. I always get a sense check, and that's what we do. We do it to calibrate our thinking so that I can be sure I'm thinking that of everything that I should be in terms of our standards, in terms of our guidance. And I'm also making sure that I have a conversation to just check that there isn't any bias in my thinking. For example, I haven't missed something because I'm busy. And in these scenarios, it's not an emergency. You've got time to do that. So with Talia, who is real, obviously I've amended details. What we did is we spent a bit of time with her over a few months, really built a rapport, and got her to a place where she was eventually in a safe house. She got a new GP whom she felt more comfortable with, and after that we were able to arrange partner notification. And the standards make clear, I won't labour this because this is a taster session and you'll be signposted to relevant guidance, but the standards show that, you know, your professional judgment, you can use it to back that up. You may disclose as opposed to you must disclose. So that's an example of a complex scenario. We normally spend about 20 minutes exploring each one, so you've got a really solid understanding of the guidance around it, and that's what we do in the workshop. But another scenario, another area that we look at is expectations. So a question for you, if we can launch, the next question, thanks Shivani. We asked 500 patients, members of the public, what they think makes a good doctor. So can you, in one word or maybe two, write down what do you think they said makes a good doctor? Okay, safe, empathy, competent, compassionate. Yeah, it's good to see compassion as one of the key ones there, that non-judgmental thing. I'll show you what got honest, safe. All of them come up. The one word, and bear in mind we had 500 people there, that really came up was listens, which aligns with compassionate. You can see compassion here, the empathy that you talked about, honesty. Skills and competence came up, but they weren't as big as the things that all really follow under communication and compassion. And what we find in UK practice is it is that relationship that matters so much, and doctors, well, clinicians, doctors and nurses are the most trusted profession, and this comes up every year, time and time again, and you perhaps won't be surprised by the least trusted professions. I love how it says politicians generally. It doesn't even specify, but yeah. So that is one thing in UK practice. Yes, there are huge challenges, as there are anywhere, but there are very particular challenges here. And we've talked about some really difficult areas, which we'd explore a lot more in a longer session. But one thing you have got here, there is immense trust, there is immense respect for the profession. And I just want to conclude by sharing a video with you that provides some top tips and thinking around UK practice. So we'll watch that before wrapping up. Ooh. There we go.
Well, when you first come to the UK, it isn't anything like what you've got back home. I came in the middle of winters. It was cold, it was wet, and it was an alien environment. And the initial impressions were that I'd find it very difficult to settle down in this country. But then over time, you start getting used to the workings of this place. You start getting used to the people, and you quite enjoy all the good things that go on here. You enjoy the way medicine is practiced. You enjoy the chemistry that forms within people, and you get settled in.
When I moved to Lancashire, I had great challenges in terms of the local accent. I remember my first war down was with a sister who kept calling me love or duck, or Chuck, and I found it hard to understand where that came from. But it's that, and gradually you come to realize And you've got to adapt it and make it your own. Because if you're going to live in a local place, in a country that's not your own, you suddenly have to take on a number of aspects of the local culture without losing your own.
Early days in the NHS were interesting. It was quite exciting.
And I've just paused it there to just double check that you can see that all the sound is coming through absolutely fine, and so that you can reflect on each of the points as they go through. But it looks as everything is fine on the sound, so that's brilliant. Perfect. So, thank you. So I'll carry on playing that for you now.
And at the same time, it's extremely tiring. Obviously, because English isn't my first language, that was hard from that point of view. So just to concentrate all day in English was quite a strain. So pretty much you'd come back home absolutely drained. And there's loads of abbreviation used by the doctors here in the hospital initially when you're not used to them. First couple of rounds in the intensive care, I didn't understand a thing what's been going on.
I think using simple words and simple language, which is a non-medical language, to talk to the patient is very important. And it's one of the issues that I was struggling when I came, because the terms is totally different from the medical books to the normal daily language. So that's why I was asking my colleagues, I was asking the nurses to be with me every time I speak to the patients. So sometimes I don't understand what they're saying, what they mean, and they don't understand what I mean. So to avoid this mismatching or misunderstanding, I was asking someone always to advise or to give me a help.
I didn't know how the NHS worked. I didn't know many common things. Like, for example, in India, when the patient is ill, I have to tell the whole family. But here, patient confidentiality is a sacred cow. So I had to learn that in a hard way. And not only that, within a week of coming here, one of the nurses told me, "Dr. Prabhu, you are very rude." And I was shocked. It really was a shock to my sister. And I asked her why. She said, "You don't say please and thank you." And I learned. Today my wife thinks I'm a wonderful husband, because every time I say please and thank you.
I had a chat with one of the senior sisters, and she said, "Look, you talk to the nurses as if they're your handmaidens, and they're not." And that came as a surprise to me, because I hadn't realized I was doing it. And I thought of myself as somebody, quite enlightened and all for women's rights and things like that. The way I behaved was appropriate for the system I had trained in. It wasn't appropriate for the system that I was working in and I'm working in now.
The one thing that I wish I'd known when I first started was to not be afraid to ask for help. I think medicine is very hierarchical, and you're quite frightened of your seniors in some ways. Sometimes when you're a junior, you worry about asking for help. You think it's something that you don't know what you're doing. But in reality, the opposite is true. You absolutely have to ask people for help. There are loads of situations where you, particularly as a junior, you won't know the answer. And the way that you learn and get better is to seek help.
If you don't know something, always ask for help. Turn to your seniors, ask for help. Let the patient know that you have certain limitations and you actually want to discuss that particular thing with your seniors. Patients are always happy with that. I've done that here. When I came to this country, I was not very comfortable with certain issues. So I always used to tell my patients, see, I have examined you, I have seen you, I understand this is your problem, but I need to talk to my consultant, and I'll come back to you within 5 minutes with a final opinion. And they all used to be happy. Never had any problems with them.
If you're honest and forthright and communicate well with the patient and tell them information and the results of investigations, I think you won't go far wrong. Failings come when patients are left in the dark, and then all of a sudden they're given all this information and they feel a bit overwhelmed and they don't think they've been kept in the loop. So mainly I think patients should be kept in the loop and kept up to date with everything that's happening. At the end of the day, we wouldn't have a job without patients, so they really should be the centre of NHS.
Patient and doctor relationships can be difficult, but it is the relationship that's difficult, it's not the patient that's difficult. I think there are a number of options. A number of options are that we just have to work with that, seek guidance and help from our colleagues if we can. Sometimes we ask our colleagues to see that patient because we've run out of ideas. There are other occasions where you realise that is one of those patients that you have to just have that relationship with and work with them the best you can within the constraints that the NHS has got.
You involve the patients in the decision making, and sometimes this backfires because you say to the patient, and what do you think? And they say, but that's why I've come to you, doctor, because I want the answer. So you have to be careful. You have to assess that as you go along. They want someone who they can trust. They want someone who they think will look after them.
You're a doctor 24 hours a day, and you have to be professional in all walks of life, whether this be on a Saturday night, if you're out with your friends, you have to maintain a professionalism. You're in the public eye, you're going to be around people that know that you are a doctor, and you certainly want to give off a strong and positive vibe, not to damage the reputation that a doctor carries.
We have the advantage of having different disciplines work with each other towards a common goal. Very important to actually work with different professionals with that vision of actually making sure that patient care is the center of whatever you do. It's important to respect colleagues, whether they're senior or junior, either in their clinical training or where they come from. And work as a team.
That is what we do day in and day out. When we talk to our patients, when we talk to their relatives, when we talk to our team members, because there are some teams will have 20, 25 different professionals. The communication skill is the backbone.
Confidentiality is a big issue. You don't want to breach data protection. You don't want to breach good medical practice guidance of the GMC. Every doctor learns over time that confidentiality is paramount to your relationship with a patient.
Practice of medicine is, in this day and age, with the internet and access to media and resources, is pretty much becoming uniform around the world. It is the cultural aspect of that practice that is so different.
As a doctor, particularly if you want to be a good doctor, you can't stop, because the medicine is evolving constantly. So if you stop, you're never going to be a good doctor.
I have so much to learn and so much to develop myself. And I think even if 10 years later, when I'm in the position where I'm a senior consultant, I would still have things to learn. Medicine is an evolving field. You always have new techniques and new knowledge to gain.
It's always better to question a decision, not definitely know detrimental, but feel might be detrimental, even if later on it turns out that perhaps you were wrong. Even a small chance of doing the patient wrong is unforgivable.
Teamwork is absolutely vital in the NHS, and everyone's realised that if you all work together, you achieve so much more.
When patients brought in their print-offs from the internet, I found most of the times it was helpful because it helps you understand their knowledge base. Sometimes you would have to disabuse them of what they'd looked up because, of course, it was completely wrong. We've got modern mobile technology and we have to incorporate and utilise that in our work.
Everything has to be done properly with the documentation, timing, dating. Everything has to be documented, when and who did it.
Certainly, if you're using the likes of Twitter or Facebook, there's very much a strong chance that people can see your pictures, what you're posting on people's walls. And you got to be careful what you're saying. It might be interpreted the wrong way.
If you are a doctor, you get a lot of respect, especially in your social circle. And people do respect you, and they do come to the problems. And once you solve the problems, they feel good about it.
The dignity of the patient is probably one of the patient's primary concerns and should be a doctor's primary concern. In hospital, with the way wards are set up, obviously sometimes that's not possible. If a patient feels that their dignity has been infringed on, they'll be very annoyed and it'll be very hard to achieve a good relationship with them again.
You're seeing patient after patient and you've got 10 minutes each, or you've got a whole load of other things to do. It's a job, you're doing it again and again. Whereas for them, this is probably a pretty serious point in their life. They've come to hospital or a doctor for a problem that they're worried about. It's essential that you remember that, and I think it is easy to forget.
Medicine is a risky profession. It's a noble profession, but it's a risky profession. If we miss important symptoms, if we miss important signs, a patient will be harmed. So the most important thing is take a good history, listen to your patients, and one more thing is document very legibly so that somebody else can read your handwriting.
Okay. Right. So I hope that was helpful. I'm conscious that we are a little bit over time because I can't see the screen at the same time as the video is playing, unfortunately. But just to wrap up, as I say, just bear with me. Trying to move on from the slide and it won't let me. There we go. Have a think about what you'll take away today. And there are loads of resources. I've had a look at a couple of the questions, and there's a question around routes to entry. Our routes are all available on the GMC website. So have a look at that. But my strongest takeaway for you is come to Welcome to UK Practice, and again, which you can access on our website, and avail yourselves of all of the resources. Yes, there are challenges. There are so many opportunities as well. And as our colleagues, you saw colleagues in the video who are internationally qualified, for your information, a number of them are very, very senior colleagues in the system now, so you can do really well. You can have a really good career here, and thinking of those tips, availing yourself of support, that's the best advice that I can give you. And I really hope to see you in our induction courses in the future. But thank you very much. I hope that was helpful, and I will let you have a bit of break before your next session. Cheers.